Dear my students, very good morning to one and all. Myself, I am Dr. Arun, Associate Professor, Department of Conservative Dentistry and Endodontics from Sankaracharya Dental College. Today we are going to see a topic on recreating non-vital tooth to vital. So as your name implies that we are going to create an vitality to the lost tooth structure, lost vital tooth structure. It is a new regenerative endodontic treatment approach. Clinically, we are trying now, and it's showing very good result. And future, these are the one of the clinical very important trend in gaining a non-vital to vitality. So first, in this treatment approach, first we are going to see about the pulpal diagnosis and their pulp test. So first, if initially patient comes to our clinical enter into the clinics, so first initially what we will do, first we are going to see an teeth clinical condition as well as the diagnostic approach, and followed by the further investigations, followed by the radiographical investigation and clinical investigations. So first, before starting a treatment, first we have to start with an diagnostic approach, and first we have to diagnose the cause, and we have to conclude with a treatment plan. So first the patient comes into the tooth clinical chair side, then first we have to see the vitality of the teeth. So normally the vitality of the teeth get affected and damaged due to only two reasons. One is dental caries and another one is trauma. Of course, we all know that, but in case of trauma or dental caries during eruption period, especially in case of anterior tooth structure, okay. So if any cause dental caries or trauma damaged the teeth vitality during the eruption period, then there will be a immature permanent teeth can be observed in the patient tooth. Then followed by, we have to maintain it is very difficult to maintain the vitality in that immature permanent tooth, and there will be a problem in developmental stage of root development as well as complete closure of the apex. So in this condition, normally what and all we can observe, that is pulp gets infected. So once the pulp get infected, what we will do? Either we can go for any endodontic approach, or we have to see first we have to see the pulpal diagnosis. So in case of pulp, once in case of trauma or dental caries, especially in case of young permanent tooth, that is during eruption period, during root complete closure period, in that condition, if pulp is get infected, what are the treatment approaches? Only one approach, that is apexification, that is removal of the infected, that is necrosed or infected pulp from the tooth, and we are going to close the apex by use of artificial cement, and that is what calcium hydroxide. This is what the apexification procedure. So once the calcium hydroxide if we place and if we complete the apexification, we can go for an final completion of root canal. So what is the main goal of apexification? Apexification is only to close the apical portion of the root, so that the obturating material cannot enter into the periapical region and the periapical region cannot be violated. So this apexification, it induces apical closure, but it will not maintain the pulp vitality. So in this condition, so to alternate to the apexification, and also we have to give some vitality to the tooth structure, Branks and Trope is the first author to introduce regenerative endodontic treatment approach. This procedure is suggested that replace the damaged non-vital pulpal tissue with the viable tissue, that we will we will discuss in further slides, okay. So first, the apical periodontitis, once the tooth gets infected, apical periodontitis, if any pulp gets infected, we can go for an endodontic approach. If the pulp gets infected, then it leads to an apical further periodontal loss got started, apical periodontitis is developed, then this regenerative endodontic treatment is not at all considered. Once the main aim of the regenerative endodontics treatment protocol is you are going to induce the vitality to the tooth structure. So the pulp, where is the pulp, will grow from the apical region. If any apical periodontitis, or if any loss of periodontal structure, or if any severe periapical infection is present, in that condition the periapical region has no chance to stimulate the stem cells or whatever the vitality to the tooth structure. So in case of any apical periodontal condition, the regenerative endodontic is not considered, it is contraindicated. So these procedures used, the case reports are based on the concept that stem cells have self-generating capacity and are multipotent cells. So this is the main theme, main concept of the regenerative endodontic treatment is the background. How this regenerative, this pulp gets vital only because of two things. One, the self-generating capacity of the stem cells, and these stem cells are multipotent. So the main theme of regenerative is completely based on stem cells. Okay, these stem cells only will get induce the vitality to the tooth structure as a pulp vital like tissue. Okay, so then the stem cells are to induce pulp regeneration to treat immature permanent teeth in a conservative also. So in case of any conservative approach, if you want to go for regenerative, yes, of course you can go. Now coming to the treatment difference between the regenerative and the apexification, you all know that apexification, after opening the canal, once clean the root canal, at the apical site you have to place an calcium hydroxide or MTA as a apical stopper, apical closure. So initially the apexification, you have to go for an calcium hydroxide medication long term, that is it has to be replaced every 3 months, and the periapical region has to be subsided, the infection gets subsided, then it has to go for calcium hydroxide or mineral trioxide aggregate, MTA apical closure. These are the two cements which widely used for apexification, and this calcium hydroxide is a older material and MTA is replaced with the calcium hydroxide because MTA has a good setting time, it will set in 24 hours, and calcium hydroxide it will take another 1 month to complete setup. So repeated radiograph has to be taken for this any apical closure, the cement, dental cement has been set properly or not. The repeated radiograph has to be taken in case of calcium hydroxide. Whether in case of MTA, if you place an MTA after 24 hours, the cement gets sets after initial 4 minutes, initial settings time will get starts for MTA, and final after 24 hours, the final setting time will get complete, so that the MTA sets within 24 hours and it has a good biocompatibility. But the main disadvantage, main drawback for this calcium hydroxide as well as this MTA, it increases the possibility of the root fracture and developing defects, that is root walls, due to porous in nature. So if you take a set mass of calcium hydroxide, okay, if you do the cross section, if you, for example, if you take any duster, any sponge, if you cross section the sponge and if you see, there will be a round hole, round space will be present, same like that only calcium hydroxide. If histological cross section has been done and if it is observed under any microscope, the set mass, it has a porous in nature, some gaps and small holes will be present. Because of this, the set mass also will get fractured, and after some time the MTA or this set mass will initiate a root gets fractured because of force get exerted from the tooth crown part to the root surface, and then this porous in nature set mass cement will get fractured, and this will cause root also get fractured. So this is a very disadvantage, drawback for the apexification procedure. So to overcome all this, only this regenerative has been introduced. Regenerative is here, it will helps in develops a complete root development in a short time and also causes increase in the root length as well as thickness in the root dentin. This is the two very important point. So in case of apexification, we are going to give only a cement which is artificial. It will not helps in the closure of the root. It will just act as a stoppage of obturating material to not to penetrate in the periapical region. So regenerative advantages, it will increase the root length and also increase in the root thickness, and also it will cause vitality, pulp like tissue will be get started, initiated. Okay, this regenerative endodontic treatment, what is basically it involves? It involves first is disinfection of the root canal by using antibiotics. Okay, now we all know that intracanal medicaments plays a major role in case of disinfection. So in case of, if you want to go for regenerative endodontic treatment protocol, I will show you the protocol next further slides, but before that you have to know, in case of regenerative endodontic treatment protocol, the root canal will get disinfected only by triple antibiotic paste. Calcium hydroxide also can be used, but unless and until if you not used triple antibiotic paste, you can't expect a good vitality, you can't expect good result in case of regenerative. So what are the three antibiotics? As Hoshina they have introduced, they have stated that in 1996 antibiotics, triple antibiotic paste such as ciprofloxacin, metronidazole and minocycline, these are the basic three triple antibiotic paste which is commercially available, but comparatively commercially available, if you go for commercially available, the consistency will be little bit less and the action of the triple antibiotic paste will be little bit less. So if you take ciprofloxacin tablet, metronidazole minus individual tablet and mix it in 1:1:1 ratio, and you have to weigh the gram 1 milligram, 1 milligram, 1 milligram in a proper ratio, and you have to keep that medication inside the root canal. It will show amorphous excellent result in case of regenerative. So here various studies has been stated that various aspects of regenerative treatment such as clinical features, biological features and their effects on regenerative endodontic treatment are discussed in various case reports. But everyone they have stated that this intracanal medicament plays a role in multiple aerobic and anaerobic bacteria. These are the bacteria which cause infection in the root canals. Various studies have showed that these are the aerobic and anaerobic, both aerobic and anaerobic bacteria will be present in the root canal. So these are the triple antibiotic paste which will kill those bacteria effectively. Okay, and when these anaerobic and aerobic bacteria are multiple bacteria presence, it is difficult to disinfect with only one type of any one antibiotic or calcium hydroxide medication. So if we go for triple antibiotic paste, the efficacy will be more. Even the American Association of Endodontics has been stated, they have been given, these are the proper indication for the regenerative treatment protocol. The first one is the pulp should get necrotized. Okay, so once the pulp get necrotized, you can go for regenerative protocol. If you want to go for regenerative protocol, the pulp should be necrotic and the apex should be open, it should be immature, and also the pulp space not needed for post and core. Again, in case of most of the immature open apex teeth, the canal space will be little bit wide. In those conditions, if the crown structure is very less, if those conditions, you have to go for post and core. If after treating regenerative, you should not go for post and core, then only it will comes under the treatment approach. So the three indications are necrotic pulp, immature apex, that is open apex, and the pulp space not needed for post and core. Okay. So now coming to the clinical approaches. Okay. Now the step by step we will see. It has to be carried in 2 appointments. The first appointment, the initial risk and potential benefit should be explained to the patient. That is, what are the risks for this treatment? The patient has to come 2-3 appointments, and patient have to wait for the complete development of the vital tissue, and also the risk such as the blood will be taken from the patient own hand and it will get centrifuged, and the PRF or PRP has to be separated. These are the risk portion. If during the treatment protocol the patient maybe get developed a swelling, or sometimes there may be a sinus discharge, these are some of the risk has to be explained to the patient, and also the benefits are, of course, the benefits such as we are going to give vitality to the tooth structure. So in future, if you develop if you give vitality to the tooth structure, in future, if again after 5 years or 10 years, again the tooth is get secondary infected, or any dental caries or any trauma, again secondary trauma has happened, at that time you can go for root canal treatment, and we are prolonging the failure of the treatment of root canal. That means we are going to save the tooth again more than 20-25 years. Okay, that is what the main theme. And collecting the clinical information, any systemic condition, any diabetics, any BP, any renal problem. Okay, these are the systemic condition has to be collected from the patient. Then pulpal and periodical diagnosis has to be done. So the pulpal diagnosis, of course, the pulp vitality test has to be done. Always in case of non-vital tooth, you should not carry a thermal pulp testers. Okay, you have to do electric pulp tester. In case of, if we want to check the pulp is non-vital, EPT is the final pulp vitality test, and it is the confirming pulp vitality tester also. So EPT has to be done, and the periradicular diagnosis has to be done. Any already pre-operative swelling is there, any periapical lesion that is lesion is more than 1 centimeter, more than 2 centimeter is there, these and all has to be observed properly, and then followed by the treatment has to be started. Before starting the treatment, always get the consent form signed from the patient or patient relative. Okay, patient own parents or whatever, whomever coming as an attender, you have to get the consent form, then only you have to start in case of this kind of treatment. So first one, you have to administer the anesthesia. Okay, that is lignocaine with adrenaline has to, again I am telling, lignocaine with adrenaline. Okay, please remember that lignocaine adrenaline has to be administered, then rubber dam has to be applied. Again here some of them will develop a question, this is already a non-vital, pulp is necrosed, so why we need to go for local anesthesia? Of course, the lignocaine and adrenaline we have to administer so that some miss vitality is present, that we can be avoided, and also there should not be any bleeding in the first appointment while doing the cleaning. Okay, so access has been opened by use of round burr, by use of non-end cutting burr. I will always suggest whenever you do the access opening, whether beginner or you are experienced, okay, always start with the round burr in case of anteriors and deroof the dentine by use of non-end cutting burr, so to avoid any perforation in the coronal access. Okay, so once you do the access opening, go for a gentle irrigation with 20 ml of sodium hypochlorite at a very lower concentration, that is 1% or 2.5%. You don't go with an 5.25%. Even the studies has been stated that 5.25 also effective, 1% also effective. The thing is, the amount of hypochlorite is very important. That is what we are here mentioning, that 20 ml of sodium hypochlorite at lower concentration, that is 1% or to 1.25%. This is enough. This is more than enough. If you go for 5.25% as 20 ml, sometimes this hypochlorite, already the apex is opened, so hypochlorite may get penetrate into the periapical region and it may cause a killing of the stem cells, or it may cause degradation of the stem cells. So we can't achieve, you can't accept stem cells proper viability. Okay, so we should not kill those stem cells by inducing high concentration of hypochlorite. So for that only AEE guidelines has been given very detailed, that administer only 1% or 1.25% of 20 ml, or if you go for 5.25%, it is 2 to 4 ml is enough. Okay, so we have to follow certain guidelines. So AE guidelines, gentle irrigation with 20 ml of hypochlorite at a 1% or 1.25% concentration. Then you should not use any files inside the root canal. This is very, very important. You have to only, you are going to, your goal is you are going to remove the infected pulpal debris. Okay, so you are not going to shape the root dentine, you are going to only remove the pulpal debris, infected pulpal debris. Okay, so gentle irrigation, you should not use any files, rotary or hand files, whatever. Okay, then by using a pepper points, you have to dry that area. After that, you have to place a triple antibiotic paste, that is what antimicrobial medicament has to be applied. Okay, then proper after antibiotic paste, triple antibiotic paste, you have to place in temporary filling and wait for 3 to 4 weeks. Okay, the complete eradication of the bacteria, it will take minimum 3, that is 21 days to 28 days. Okay, so after that, recall the patient at the second appointment. What and all you have to do? First, you have to check any signs and symptoms from that periapical or tooth region. You have to ask the patient whether any pain was developed in these 3 to 4 weeks, and any swelling was developed, any pus discharge, and also you have to observe the periapical region, and you have to see the gums, either any swelling is present, inflamed, or any color change is present. These are all you have to observe. If any acute infection is present, okay, that is what any sinus opening or any pus discharge or any periapical swelling. Then here again, after observing that any symptoms and signs, if there is no signs and symptoms, you have to proceed with the treatment. You have to start up with a second follow-up, that is LA without adrenaline. Again, in first appointment we had used LA with adrenaline. Here LA without lignocaine, without adrenaline. Because why? Already adrenaline, what is the main action of adrenaline? There will be vasoconstriction will be there. There will be a clotting. Okay, the blood flow will get reduced. So in this today in second appointment what we are going to do is we are going to place an PRF or PRP. So if we want to place these stem cells there and it need a good viable good blood flow region, okay. So for that without Radulin we have to administer the LA and blood flow will be normal in the periapical region, okay. Then rubber dam isolation has to be done, again the temporary restoration has to be removed, and the triple antibiotic paste is it should be removed by using of 20 ml of EDTA solution, okay. So in many of them will have doubt that how we have to remove the triple antibiotic paste. So always only by use of saline triple antibiotic paste we can't remove, and also by use of chlorhexidine we can't remove. If you want to remove the triple antibiotic paste properly completely, you have to use then 20 ml of EDTA, that is given by AEE guidelines, okay. Then followed by final irrigation solution is saline. Once the medicament got removed, use a paper point to dry the canal, and here the two things are very important: regenerative. Okay, regenerative means we are going to place an scaffold. We are going to place PRF or PRP inside the periapical region. Okay, so revascularization. One more thing is that is revascularization. The two difference between revascularization and regenerative is nothing but till drying the paper point same method. After that, if you put a file inside the root canal and if you induce the bleeding from the periapical region, that is what revascularization, okay. So in case of revascularization procedure, you can't expect that much viability of the pulp as well as root development. So only along with the revascularization, regeneration also we are trying now. That is what either you can induce the bleeding and you take the blood from the patient's own hand and centrifuge it at 12,000 cycles, then separate the PRF from the blood and place on the periapical region. If you want, you can go with the revascularization, regeneration. If you want only regeneration, yes, of course you can attempt only regeneration. Actually the study stated that bleeding is only for revascularization procedure. If you want good blood flow in the periapical region, of course you can go with the revascularization along with the regeneration, okay. So if you want, you can induce the bleeding just for 1 or 2 mm is enough. 1 mm is enough, only at the periapical region is enough. Then followed by place a scaffold, that is PRF once placed, once prepared, that PRF and we can go and keep it in the periapical region. This all should be done under only rubber dam isolation and proper sterilization, okay. So once the bleeding is induced or once the PRF scaffold is placed, okay, then the cola plug resorbable matrix has to be placed over that periapical region, that is over that canal where you placed a scaffold, and then 3 mm MTA has to be placed as a final restoration. Again MTA is a good biocompatibility and also it is set in the wet environment. The only cement which is set in the wet environment is MTA. So these are the very good advantage for the MTA. So after placing in PRF, you have to go for MTA, okay. Then wait for 12 months, 12 to 18 months. Then after 12 to 18 months, that is after 1 year, 1.5 years, you recall the patient and take a X-ray, okay. You can able to observe the developments. Now coming to what is the difference between this regenerative endodontic treatment and the pulp treatment procedure, that is what apexification. See, in case of regenerative, that is reinforcement of the dentinal walls by deposition of hard tissue. It is a cementum like tissue or pulp like tissue we can able to see it will get grown, okay. In case of apexification, I already said that calcium hydroxide MTA2 material, calcium hydroxide, it acts as a calcified apical barrier. It will not induce any root line, that is what the reduction in the root line and also possibility of the root fracture because of that set mass and multiple visit we need for this to accompany, okay. Whereas MTA, this is 1 or 2 step, only 1 visit or 2 visit is enough and it will strengthen or not promotes root development. This will also same, the calcium hydroxide as well as MTA, it has same setting mechanism, okay. But The only thing is setting time is different. Setting time MTA is little less, and calcium hydroxide it will take 1 month or 1.5 months also. So the roots will be very thin and fragile. So MTA, whatever the MTA or calcium hydroxide, the set mass will be present after 5 years, after 6 years. Once the treatment got completed, after that post-operatively 6 months or 10 years, 6 months or 5 years or 10 years, once the patient gives a repeated stress on the tooth structure, there may be a chance of getting fracture on the root surface. So the various studies has been stated that comparison of radiographic and survival outcome of these immature teeth by regenerative endodontic as well as with apexification, they compared. They have observed that revascularization or regenerative treatment, which has showed 28.2% of root width increased and 14.9% of root length got increased, wherever in case of apexification it is not that much up to. Okay. So this regenerative advantage is promoting root development, thickening of dentinal walls by hard deposition of dentin. Okay. So what is this regenerative? Actually, what is the main source of this regenerative? That is what the two cells plays a major role. Okay. Regenerative immature teeth, it is used mainly in the immature teeth because of mesenchymal stem cells exiting stem cells from apical papilla. So in case of apical papilla, in case of periapical region, what is the stem cell will be present? Always you know that stem cells in the periapical region, that is what stem cells from the apical papilla. These stem cells from the apical papilla and the dental pulp stems, this is also in the periapical region, which is attached to the root dentin. So these two stem cells only plays a major role in the regenerative protocol. So this cap, that is stem cells from apical papilla, which is differentiates into odontoblast like cells, and this helps in root dentin formation. Whereas dental pulp stem cells differentiate to odontoblast like cells, form dentin or pulp like complex. So these are the both cells, two cells which plays a major role, and it will helps in developing the root dentin as well as the vitality to the vital pulp like tissues. Okay. So these two stem cells, it has an potent in osteo or dentinogenic differentiation as a mesenchymal cells from bone marrow, but these have very weaker adipogenic potential. These two cells have some similarity and some differentiation. All the cells have both are similar only, but the difference is number of doubling the population, that is stem cells from the apical papilla have more doubling than the dental pulp stem cells, and the tissue regeneration capacities stem cells from the apical papilla is more than the dental pulp. So only we are keeping these stem cells, we are keeping that PRF in the periapical region to develop a tissue regeneration. Now coming to the very important factors, these are the three factors which it was given by AAE as well as endodontic glossary has been accepted, and these are the three factors you have to remember. That degree of infection of control in case of regenerative protocol. So impossible in case of any infection with a larger infection size is larger than 1 centimeter, it is can't able to go for a treatment. Okay. In case of normal regular infected tooth, you can go with a triple antibiotic paste as well as calcium hydroxide in case of follow-up. So both that medication can be used. Okay. In case of apical diameter, then the second factor is apex diameter, that it should be more than 1.1 millimeter. Why it should be more than 1.1 millimeter? Because the PRF, the scaffold what we are preparing, it will be keep in the periapical region. If the size, the open apex, if the apical size is more than that, it is open more than 1.1 mm, so that the tissue can be easily placed in the periapical region. And the patient age is 8 to 16 years. This is now the recent 2022 AAE guidelines has been accepted up to till 22 years can be done, 8 to 22 years. Okay. In case of deciduous or milk teeth, it is completely contraindicated. You should not perform any regenerative procedure. So medicament used here is triple antibiotic paste is recommended. Why? It is composed of ciprofloxacin, minocycline and metronidazole. We all know that. And the second one is calcium hydroxide. It has a complete disinfection as well as regeneration capacity. But in case of triple antibiotic paste, calcium hydroxide, formicocel, whatever, it has produced significantly greater increase in root length and width only after placing the scaffold. Okay. So in case of triple antibiotic paste, it produces greater increase in dentin wall thickness. The width of the dentin wall thickness will get increased even some studies have stated that triple antibiotic paste also causes this thing, but the only thing is triple antibiotic paste will completely disinfect the canal. So the regeneration, the dentinal cells able to differentiate to form and further cells. That is what they have given. So now coming to the drawbacks of this triple antibiotic paste, sometimes after placing a triple antibiotic paste, the patient may develop pain, but it will be for some days, 1 or 2 days, it may get automatically subsided, and sometimes it may develop a sinus tract, and discoloration is the major cause of the major drawback of this triple antibiotic paste, that is minocycline has been used in this. So this triple antibiotic paste is completely contraindicated in case of 3rd trimester patient and patient less than 8 years. It will cause compulsorily discoloration, and there is a reduction of bone growth, and the amelogenesis imperfect also sometimes can it generate. So the methods to prevent discoloration are sealing the coronal dentinal walls with the flowable resin. Of course, we all know that once you place the PRF inside the canal, after that MTA has to be placed. Before placing MTA, you can give some sealer, okay, at the coronal orifice. You can give some flowable composite resin, or in case of first visit before giving a temporary restoration, without applying bonding agent, you can go for flowable resin to avoid any leakage, any penetration of minocycline byproducts into the tooth structure, and it will cause discoloration. Okay. So retrograde filling of antibiotics with 20 gauge needle to minimize the contact with the coronal. So the triple antibiotic paste has to be kept in the periapical region. It should not be completely get contact with the dentines, root dentinal walls. Okay, there should be minor space should be maintained, and it should not be placed up to the coronal pulpal region. Okay, even the case reports suggesting that cefaclor amoxicillin instead of, because of this minocycline is causing discoloration, to replace this cefaclor and amoxicillin also can be used. The studies has been stated. And why we are using MTA as a final restorative material, because it has a good biocompatibility and sealing ability, and as earlier I said that it is set in a moist environment, that is wet environment, such as the bleeding area of the tooth structure. Regenerative endodontic treatment is based on concept of multipotent stem cells from the apical papilla, that is CAP, as well as DPSC. This has greater differentiation capacity other than the other stem cells and attached to root apical area. This has be able to maintain their vitality through collateral blood circulation also. So MTA final filling material, it allows cell proliferation and cell attachment because it has less cytotoxicity and good biocompatibility. It enhances the tissue healing process and prevent the weakening of the dentin structure, which was caused by long-term administration of calcium hydroxide. Okay, so for this only we are avoiding calcium hydroxide for long time. Okay, so this procedure is conservative concept that recommends treatment by induction of pulp regeneration like tissues. If the procedure fails, of course the conventional root canal therapy should be preferred, and this has to be explained by the dentist to the patient before starting the treatment. And thank you my dear students watching this my class. If you have any doubt, you can approach. Thank you.